Hello everyone, my name is Pedro Amarante Andrade. I am a speech pathologist from Brazil, and I am now living in the Czech Republic, where I work as a researcher at the Academy of Performing Arts in Prague. The topic of today is muscle tension dysphonia, and that is the client group that we're trying to address in one of our studies, in which we're looking at some physiotherapeutical principles that could be applied for patients with voice disorders. In this session today, I'll be talking about the definition of muscle tension dysphonia, the prevalence, some of the causes of muscle tension dysphonia, also how it presents, some of the assessments that we normally do in the clinical practice, and then some of the treatments as well. But before we start talking about all of that, what is muscle tension dysphonia? The term muscle tension dysphonia is widely used among vocologists and ENTs and speech pathologists throughout the world. But this condition has been known by other names as well. For example, laryngeal tension fatigue syndrome, hyperfunctional voice disorders, functional dysphonia, or muscle misuse dysphonia. And all of these terms describe a condition in which there is an excessive amount of muscle activity that is causing problems with the quality of the voice. A good definition of muscle tension dysphonia was given by Stempel, and it says that muscle tension dysphonia is a disorder of the voice use that occurs despite the presence of normal vocal fold structure with no evidence of neurological disease or psychological abnormalities. So pretty much the larynx itself is completely fine. There is no signs of lumps, bumps, no problems. There's no problems with the nerves that come down and innervate the larynx. Also, there is no psychological issues, yet the voice is not normal. With regards to prevalence, between 40 to 70% of voice patients are diagnosed with muscle tension dysphonia. And about 40% of professional voice users, those are people that rely on their voices in order to work, are also suffering from muscle tension dysphonia. And about 1/3 of female teachers suffered or are suffering now from muscle tension dysphonia. So it's a highly prevalent condition. And here I have two studies that show how these professional voice users are at a high risk of developing muscle tension dysphonia. The first one looked at the condition of the larynx after asking some subjects to speak with a harsh voice quality for as little as 15 minutes. And what they found was that the larynx starts showing some signs of inflammation. The other one looked at the quality of the voice post-performance, and they found that the voice becomes hyperfunctional. So if you are a singer or an actor that use your voice extensively and have to vary the way that you produce your voice, you are certainly at a higher risk of developing muscle tension dysphonia. Okay, and what are some of the causes of muscle tension dysphonia? We know that muscle tension dysphonia has a multifactorial etiology, which means there are different elements contributing to the condition. For example, you have vocal misuse, abuse, phonotraumas. You have psychogenic or emotional factors as well, which makes sense because since a young age we tend to vocalize our emotions. We cry, we sob, we scream, and so on. But also you have, for example, compensatory gestures, in which you have a condition that affects how you're projecting your voice, how you're using your voice, and then you try and overcompensate and you tighten the muscles around the neck to try and push your voice. Another condition that is very common is the gastroesophageal reflux disease, or GORD. And that is a condition in which acid from your stomach will go up through the esophagus and then go into the larynx and burn the surface of the vocal folds. And what happens is that will make it harder for you to phonate, so then you try to overcompensate and engage the muscles, and then you develop muscle tension dysphonia. Okay, so what are these behaviors that could cause muscle tension dysphonia? For example, if you have to use your voice for long periods of time and you have to project your voice over some background noise, that's certainly going to put some strain on your vocal apparatus. Also, if you use what is called pressed phonation, in which you tighten the larynx as much as possible in order to project your voice, could lead to muscle tension dysphonia. Now, there is also the onset, the way that you start your vowels. They can be quite soft and gentle, so the vocal folds come together nice and softly, or you can actually slump them together, and that if you do it repeatedly, which you will do in the context of speech and how many vowels you produce in a day, that will cause some damage to the vocal folds. I want to spend some time showing you this vocal attack, and I want to show you two types of attack: the harsh vocal attack and the soft vocal attack. So for the ones that are not very familiar with the anatomy, so here you have the vocal folds, and then in the middle you have the glottis. Here is the front of your neck, and here is the back of your neck. So behind here is the esophagus, and here you have two big bumps, and those are cartilages that come together to bring the vocal folds together in order for us to speak and produce our voice. Now what I want you to pay attention is to the amount of vibration on the surface, or some sort of oscillation of the vocal folds before actually they touch each other, before this side will touch this side. And I want you to count with me how many times it will take for them to touch. 1, 2, 3, 4, well, between 3 and 4 I would say. This is the harsh attack. This is if you go ah, ah, that will be a harsh attack. Now let's look at this one. How many oscillations? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, and now they are in contact. And as you can see, there's a very soft contact between left and right vocal folds. They come close, they start oscillating, and then suddenly they touch each other. Now this, what I did here, I just put a small H sound before the R, when ha, right? But well, actually it was smaller than that, was ha. So if you look here, now I'm just going to look at the same thing with the context of the EGG, so electroglottography. So these are electrodes that you put around your larynx, and they produce a very small current through the larynx, and they measure the contact between the vocal folds. So every time they see a bump like this, that means that the vocal folds are in contact, and then they open, and then you don't have contact anymore. So here will be contact, and lower here will be without contact. And here this is the same signal, but then in red you have the signal from the microphone. So let's have a look at this video. This is the harsh attack. 1, 2, 3, and then you're already seen here. There's a bump here and a bump here. So there is one bump from the microphone, which is the oscillations, change in the air that comes from the vocal tract into the microphone. So you have here 1, 2, 3. On the third one, then you have the contact between the vocal folds. Now let's look at the soft. This is the soft onset. See here, there's some oscillation going on, and then the vocal folds now touching. Okay, and again, very gentle touch between the vocal folds. Now if you look at the bumps, you see there is things happening here in the microphone signal. So maybe 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, and then you have a signal on the EGG as well, showing that there is some contact between the vocal folds. So this was harsh vocal attack. Also, you need to be careful with shouting, so trying to raise the intensity of your voice. When you cough a lot and you clear your throat a lot, that can also hurt your vocal folds. So let me show you here what happens when you actually clear your throat. So here what you have is actually the larynx, so the glottis is closed, and the supraglottic structures are also closing as well. So they're going to generate a lot of subglottal pressure, and this pressure is going to be released. And I want you to pay attention to the vocal folds and how they slam shut, primarily at the very front part of the vocal folds, and how hard they come together. So let's see here. This is air escaping, so release the air, and then they start vibrating, and then they slap together right in the middle there. So let me just put it back. So now, did you see they clapping together? Look at that. That's very aggressive, and that can certainly damage that part of the vocal folds. Okay, so of course there are some other issues as well. So if you use poor resonance, which means that then you don't have the high harmonics that will carry on your voice away, so that can lead to some sort of overcompensation and overuse of the muscles. Also, we cannot forget that children also suffer from muscle tension dysphonia, and so when they play and they make sounds of cars, trucks, animals, and so on, they produce these very harsh and very unnatural sounds for them, and that can cause some muscle tension dysphonia, and that needs to be addressed as well. The other thing is also related to the technique that the person is using. So if they've been properly trained and they learned how to use their voice, how to project the voice, that is quite good. But if they just learn by doing it, then maybe they adapt some sort of bad habits, and they might be doing something that could cause some damage to the voice. Okay, some of the complaints that your patients will have is that they will say that the voice quality is husky, hoarse, it's very breathy, they cannot project their voice, they lose range, so they cannot produce the high notes. They also have these odd breaks in their voice they cannot control. They suffer from fatigue. They said, oh, by the end of the day I'm very tired, I'm really struggling to keep my voice going, and they tend to say that, you know, there's a lot of pain around my neck, there's a lot of tightness. So those are some of the symptoms that they will present. Okay, there's also vocal tract sensory symptoms, and those are the feelings that your client will have inside of the larynx, and they will be able to describe them. So some of them are linked to inflammation, and they will say that, you know, I feel this burning sensation, my throat is tickling all the time, it's very, feels bruised. And some of them are linked to the muscle usage, and they feel that's very aching, it's very tight, it's hard for me to project my voice because of the pain around my neck. And they also can complain of a lump in the throat, which is almost a separate condition, which is called globus pharyngeus, and that is this feeling of having a lump in the throat. And when you look down, when the ENT do some investigation, there is no bumps there, no lumps, nothing. And also there is this problem that, for example, if the muscle tension dysphonia is linked to, let's say, acid reflux from the stomach, that will cause irritation on the mucosa, and the mucosa will produce more thick mucus, and that's going to stay around the neck, and then you have to clear your throat. So now you have two problems. You have muscle tension, you have acid reflux, and you have this thick mucus that is staying around here. So then you have to clear your throat more often, and then you kind of lead into this feedback system that will cause more and more problems and lead to even worse even worse condition that will be more prone to develop a muscle tension dysphonia, or the muscle tension dysphonia is already there. There is a very useful scale that's called the vocal tract discomfort scale, and that is you can use with your client. And what you have is the descriptors here, which are the feelings that you can have in your larynx, and then you talk about frequency or severity. Sorry. So let's say burning sensation. Your client maybe says that, well, yes, I feel that, you know, there's this burning sensation throughout the day, especially after meals, you know. So then I say quite often, maybe number 3 here, between often and sometimes. And then you ask them, but how severe is this feeling? And then they'll say, oh, it's not too bad, I can live with it. So you probably give a number 1 here. And then what you do, you try and implement some sort of treatment, and then you can do this again and see how they feel about that, about the same sensation. Now, I've been talking about muscle tension dysphonia for a while now, but I haven't actually shown you how it looks like inside of the larynx. I showed you the onset and the harsh and the soft onset. I show you how it looks when you clear your throat. But let's have a look here at this video, and this is just a normal larynx with no muscle tension dysphonia. You can see the vocal folds vibrate fine, there's no problems. It's very open, there's no tightness, so you can clearly see the larynx, you can see the glottis, you can even see there is a small gap at the back here, which is the glottal chink, but it's okay, it's within normality, acceptable. And then also if you look at this region here, it's very good to pay attention to this region, because that is where you see signs of acid reflux, because the esophagus is right here at the back, and so the acid can come from the esophagus and then go on the vocal folds and then start burning this area here. So you see redness and you see some signs of acid reflux there. Okay, so the ENT is going to go and look down your throat, and then he's going to look for some features that will lead him to conclude if you have or not muscle tension dysphonia. They're going to look at the stiffness of the vocal folds, how symmetric they come together, the amplitude of vibration, how wide they vibrate. They're also going to look at the mucosa wave, which is the propagation of the vibration through the surface of the vocal folds, left and right. They're going to look at the closure as well, so most of the time your vocal folds should come together nicely and close all the way through the extension of the vocal folds. But you can have a small gap, usually is at the back, and that's called glottal chink. That is acceptable for mainly for female voices, because it's a feature of the voice that adds some breathiness to the voice. But it could be a sign of pathology, it could be a sign of muscle tension dysphonia. As I mentioned before, they're going to look for signs of acid reflux, so inflammation, some sort of redness around the posterior part of the glottis or the larynx. And they're also going to look at the supraglottic constriction, which is the structures above the level of the vocal folds that could come together to the middle line, trying to close the larynx. And that, because they're trying to close the larynx, that could be because there's an excessive amount of muscle usage and muscle tension that is bringing them together. So you have the anteroposterior, which is the epiglottis, and the arytenoids, they are coming towards each other, and so that will cause this anteroposterior constriction. Or you can have a lateral constriction as well, which is the false vocal folds or the ventricular folds. They are coming together and obscuring the view of the larynx. Now, by themselves, they not prove that there is muscle tension dysphonia, but they are an indication that this person could have is showing these signs, could have muscle tension dysphonia, because it was found that people with normal larynx, normal voices, also present these supraglottic constrictions, these features that, you know, the supraglottic structures are coming together to the middle line. Now let me show you here a classic example of muscle tension dysphonia. So you've seen from the same view as before, but you could clearly see that the front and the back are coming together at the lower level. So there's an anteroposterior constriction, so the bottom of the epiglottis is coming towards the arytenoids. They're tightening, everything is closed, it's very difficult to see the larynx. You can hardly see the glottis as well, because everything is very constricted. There's a lot of tension there, and those muscles here, they are doing things that they shouldn't be doing, and that is a very classic view of muscle tension dysphonia. Also, you can perceive from the voice that there's breathiness as well. There's a little bit of roughness as well. So this is an additional slide to show you a condition that shows some overlap in terms of presentation with muscle tension dysphonia, and that is adductor spasmodic dysphonia, or ADSD. ADSD is a condition in which the nerves are firing and are triggering the adductory muscles of the larynx, and then suddenly the vocal folds come together and then they close the glottis. So this condition shows some similarity with muscle tension dysphonia, because you see this level of muscle activation that shuts the whole glottis and also affect the supraglottic structures, and that's one of the signs that you see that are similar between them. Both of them also show MTD and adductor spasmodic dysphonia. Both show signs of irregularity in the closure, but some features are only found in ADSD, and those are phonatory breaks, and also normally sustained vowels sound better for patients with ADSD than connected speech. Now, the other difference between these two conditions is that ADSD does not respond to therapy. So in muscle tension dysphonia, you can have someone with a normal voice within a few sessions, but ADSD, you require some medical intervention and very likely Botox injection to sort of neutralize the spasms that happen to the larynx. So that is one way to differentiate both of them. So what to expect in terms of assessment for someone that has a suspicion of muscle tension dysphonia? Probably this person is going to be seen by an ENT doctor, a speech pathologist, or both of them at the same time. And what these specialists are going to do, they're going to take the case history, they're going to take the medical history, they're going to scope the client looking down the throat via a flexible endoscope through your nose or through your mouth with a rigid endoscope. Then possibly the speech pathologist will take over and then do some auditory perceptual analysis. Then they're going to probably do some acoustic analysis, look at aerodynamics, also palpate the client, look at the muscles, the condition of the muscles, and if necessary they will forward the client to a psychological evaluation. When doing the auditory perceptual analysis, the speech pathologist is going to look at some things like, for example, the glottal attack, if it's a harsh glottal attack, if it's a soft vocal attack. It's going to look at the breath support as well. It's going to pay attention to the pitch. It's going to look at tension around the neck, jaw, mouth, and so on. And also they're probably going to use some sort of scale, for example, the Garabas, which is roughness, breathness, asthenia, and strain, and there is a grade, a general grade as well. So they can use that as some sort of reference for how your voice sounds on the first appointment, and then they see the progression of the treatment as well. It has been suggested by a large committee that is specialized in voice that we should adopt the CAPE-V, which is similar to the Grabas but has some additional features, so they can carry out the CAPE-V as well in order to have an idea of how your voice sounds. The speech pathologist is also going to palpate the muscles around your neck to find if there are any signs of excessive amount of muscle activation. They're going to ask you if you feel any pain or tenderness, and they're also going to look at the height of the larynx in relation to the neck. So they're going to look at the space between the thyroid cartilage and the hyoid bone, for example. Now, it was found that patients with muscle tension dysphonia tend to raise the larynx when they phonate. So it's very likely that the speech pathologist is going to put their hands on top of your larynx and they're going to ask you to phonate. So what was found is that patients with normal voices will keep the larynx at the same level, whilst patients with muscle tension dysphonia tend to raise the larynx when they start phonating. Another assessment that can be done as well is the acoustic analysis. In order to do that, you need a good laptop or computer and a microphone that is calibrated, so you can compare your results with normative data. Now, looking at the signals obtained from patients with muscle tension dysphonia, it was found that they have a much stronger source when compared to the higher harmonics in the spectrum. Also, they found higher content of energy in the higher harmonics, and that's because of gaps between the vocal folds that produce some noise, and this noise is seen as high content energy. Now, they also found deviation of the fundamental frequency for normality, usually lower than normal. And there are three measures here, jitter, shimmer, and noise to harmonic ratio, that are commonly used for voice analysis. Jitter being the period to period variation in terms of time, how long it takes for one cycle to complete. And shimmer is the amplitude of the signal that can change across different cycles. There's also noise to harmonic ratio, which is the ratio between the sound that you want to hear from the voice, which is the acoustic signal, versus the noise that comes through the vocal folds if there is a gap between the vocal folds, for example. And all of them show an indication of voice problem. Another measure is the capstrum prominence peak, which highly correlates to how we perceive the sound and to the severity of the dysphonia. A more recent development is the relative fundamental frequency, and what they do, they look at small changes between voiced and voiceless sounds, and they look at the changes in fundamental frequency. What they found was that People with normal voices have larger changes in fundamental frequency than people with muscle tension dysphonia. So therefore, this type of measurement is very good as a screening tool or diagnostic tool for patients with muscle tension dysphonia. In terms of aerodynamics, it was found that patients with muscle tension dysphonia have a higher glottal resistance. And that makes sense because they tighten the vocal folds and therefore they increase the resistance to the flow. As a consequence of that, they also were found to have higher subglottal pressure because they're trying to push through this higher resistance in order to produce voice. They also found to have lower mean airflow rates and reduced maximum phonation time. Now, a measurement that was found to be very useful to diagnose patients with muscle tension dysphonia is the level of subglottal pressure, which is supposed to be below 8.175 centimeters of water for patients with normal voice. So if they exceed this value, that means that it's very likely that they suffer from muscle tension dysphonia. Treatment is usually divided into voice therapy, psychotherapy, and medical treatment. Psychotherapy tends to be used just for some of the clients that have this suspicion that they have some psychological element to that muscle tension dysphonia. And medical treatment is usually for patients with suspicion of acid reflux. And in order to address that, they can use Gaviscon. So Gaviscon is a medication that is taken before bedtime, and what it does, as soon as this syrup, which is Gaviscon, gets in contact with the acid in your stomach, it becomes solid, it floats, and then it blocks the passage between the esophagus and the stomach, and that blocks the acid from coming up all the way and burning the vocal folds. We also can be prescribed some other medication that will either block the production of acid or will neutralize the acid in your stomach. For the voice therapy, there is a number of different techniques that can be used. Most clients will be given vocal hygiene, which are tips and advices for how they can improve their voice. So they should drink a lot of water, avoid smoking, avoid drinking alcohol, avoid shouting, so all the abuse should be eliminated. Also looked at acid reflux, how much rest they have, and so on and so forth. They're also gonna be explained on how the voice is produced and how their condition is deviating from normality. Now there's some groups of techniques that can be applied as well. So relaxation techniques, accent method that looks at the breath support, also looks at the source to have a very relaxed larynx, and resonance as well. Same thing for flow phonation. I really like laryngeal massage. Laryngeal massage is the speech pathologist is gonna actually massage the muscles and try to reduce the tension in the muscles and try to bring the larynx to a more comfortable position, so that will counteract the effects of muscle tension dysphonia. There's also a group of exercises that's called semi-occlusive vocal tract exercises. As the name says, there's a semi-occlusion of the vocal tract, and then usually you have also a prolongation of the vocal tract, and what they do, they create increased intraoral pressure, and that's going to open up everything. And some of these exercises also have some level of oscillation of this pressure inside of the mouth, for example by doing some bubbling in a glass with water, and that change in pressure is going to massage the neck and going to relax the vocal folds, or relax all the muscles, not only the vocal folds, sorry. Also, if the person is suffering from acute pain, the speech pathologist can also use electrical stimulation in a specific tense, which is targeting the muscles around the neck and trying to relax the muscles via electrical stimulation. So this is the end of this presentation. Thank you very much for watching, and I hope it was useful for you. I just wanted to show you here, this is our website, so the Academy of Performing Arts in Prague. If you want to get in contact with us, please do it. We have a sub page there, which is vocology, voice vocology, and professional voice care, which has a lot of information about voice, how voice is produced, and how to look after your voice. So yes, have a look, and if there's anything, reach out to us. And that's it. We hope to see you soon.